just for the part of the routine, everyone knows Albert Espe. I know him for last 10 plus years. So I think first time I met him in 2010 back in Toronto. We all know Professor Espe. He's endowed chair at the University of Cincinnati. And currently he's also chair of the MDS technology at the task force of the IPMDS. He's secretary-elect of the Pan-American section of the MDS. He's honorary member of the Mexican Academy of Neurology. And in the brief, if I can tell, he's the most active person in the International Parkinson's Disease and Movement Disorder Society. I know him very well enough. And not only that, we can see him in all the movement disorder meets. And he's a voracious speaker. And nothing, you can hear him to talk about when do disorders of movement become movement disorders. Espe, please.
Thank you very much, Prashant. I really appreciate that very kind introduction. Thank you, Sudhir, as well, for also organizing these meetings. I'm just delighted to be back at this fine forum of Indian neurologists. This is a very special session to me because I'm a semiologist at the core. I think that the characterization of patients on a phenomenological level is critical. But at the same time, I recognize that the way we characterize patients could be, in some situations, problematic. And I am going to have a selection of patients that I've seen to getting to that concept. And how is it that we create these somewhat artificial boundaries between different categories? So I hope that by the end of the sessions, you'll be thinking a little bit different and hoping that not to be too dogmatic in terms of how we classify and how we do the work of clinicians. So the first thing is that this idea of movement disorders versus abnormal movements, where is that separation? The first layer is that we somehow are going to talk about movements that are affected to an extent that they become movement disorders versus movements that are affected, but yet we don't think of them as movement disorders, right? And I'm putting examples here on top. Alzheimer's disease, you can have myoclonus, but we don't think of Alzheimer's as a movement disorder. Same thing with multiple sclerosis with tremor, same thing with the stroke with dystonia and so forth. So for instance, here you have a patient with Alzheimer's disease and you see these very subtle cortical myoclonus expressed by a postural, very subtle jerks of the hands. Typically that's the distribution for cortical myoclonus. If patients can stretch their fingers, you can see it better. And then you can have someone with MS, for instance. This is a movement disorder, the tremor, but the condition, of course, is different in it. The classification, of, as you can imagine, can vary. This is an example of a cerebellar outflow tremor with head titubation as a component of that tremor. And then you have these movements that are, I call them the jerky movements of sometimes ballistic proportions in terms of the rapid and large amplitude that some of these movements could occur. These are examples of tremor and dystonia as a result of very strategic strokes. And if you see an example, as you see in the upper right corner of a right, in this case, a left jerky tremor, you have to think of ventrolateral thalamic strokes. And then here you see a patient with rather jerky ballistic dystonia due to a contralateral posterior putamen and adjacent posterior thalamus hemorrhagic stroke. So many disorders, impaired movement, are they movement disorders? That's sort of the question for this talk, and it's a provocative question because it's meant to make us think, where is it that we create that barrier? And I'm going to show you some examples that will defy the barriers that we've created. But as a summary of this initial layer of nosology, I just want to remind you of that case you saw earlier, and then a case that will be relatively in the spectrum of a patient with a myoclonic presentation on the left hand, but happens to also be associated with dystonia, with rigidity, with ideomotor apraxia, as well as cortical sensory loss. That's a cortical basal syndrome. And what's interesting here is that these two patients had Alzheimer's disease on pathology. So the pathology was identical. And that, of course, is part of a different lecture, but it is important for us to recognize that we refer to these conditions differently, even though they both have a movement abnormality, and one is a movement disorder and the other one, as far as we classify them, isn't. So abnormal movement disorders, when they begin at the onset, we think of them as movement disorders. If they happen eventually, we think of a disorder of movement, an abnormal movement that happened within the context of another neurological condition. This is the first layer. This is just based on order of appearance. Now, here's the second layer. This is a man that was seen at a video EEG monitoring unit. And as you see, there was these events on the left arm that he was having intermittently, and they were essentially evaluated on the thought that they could be epileptic, and they were not epileptic. And in fact, the man was discharged here with the possibility that because of the way the movements happened and the context around the movements, that they were functional potentially in nature. So I saw this man in my clinic.
And it's tight, and it'll start jumping. And
stop there for a second just to mention briefly that everything on the examination was normal, and as I had just finished my pull test, then the patient says, now I'm going to have an episode. And he said, yeah, it's in my, I can feel it's something here in my belly, and it's going to happen, and the rest.
In a minute, if it keeps going.
Yeah.
Can you feel the quiver?
Yeah, I can.
Okay, now there's the arm, okay? And then if I touch it, it won't choke. Now just let it go. This is the tick.
So you can stop it if you would have stopped it.
I can slow it down, and I can feel it. If you put your arm here, you'll feel the tension in the muscle. That's it. Now I got the tick. That's what I was waiting for. Okay, now it's starting in the leg. I should sit down.
Okay, you want to?
If you feel the back of my leg right here, it'll feel tight. Yeah, that'd be great. Thank you. See, I can talk, I can control it, except the left side. I can't control the left side. But if I put my arm here, it'll relax somewhat.
And it stays in the left arm.
Right now it's in the left arm. It's starting down the leg. It hasn't quite completed the leg. But this relaxes the tension of it to some degree.
What does relax? Just you touching it?
Just touching it. It's a little late. Now I'm feeling the tension in my leg, and I'll let my arm go, because the leg's more important right now. And right there, it's at this point, and it's in the toes. So if I can reach down to the toes, I can stop, even go through the shoes, I can stop the tension in the toes so it doesn't cramp as hard. I don't even need to undo the shoe. I don't need to. The arm's still going. But the toe doesn't cramp as much. That's why I don't know if it's psychological or if it's just the way the spasm works, or if it's something I can control. Breathing's gotten regular. It's almost over.
The breathing is almost over. You were breathing shallower?
I was, yeah, it was like a contraction in the stomach. That's gone. And it's 99% gone.
You put your right arm on the thigh, and yes, you can essentially eliminate the jerking?
I can nearly eliminate the
jerking. So if you had not done that, what would have happened?
It would have probably done that, the same as the arm.
The same as the arm. So the reason we did not see the jerk is because you were holding.
Yes.
How tight were you holding?
Not tight.
Not tight?
No, I just have to be there.
You just have to be there.
It just has to be there. It's almost like I can sense it go the other way.
So would have the same.
Just like the toe. I don't have to actually feel skin.
You just touch.
I just have to have. It's almost weak. I don't know why, but for some reason it recirculates the direction of it stops the extra movement.
Mm-hmm.
And it controls. I can't quite do it on my stomach, but even that has slowed down. If I had just let it go, you would have seen a much more dramatic.
So the left arm jerking as it was, you could have actually stopped it.
I could have nearly stopped it
by holding the left arm.
by just putting my hand.
Putting your hands, not even by holding
my hand there. I'm not holding it back. Just putting my hand there.
Okay.
In fact, I've been able to completely stop it from going through the arm and through the leg by just putting my hand on my stomach while it's happening. It's like it didn't reach those areas. It got subtracted right there. But if I put my left hand here, that doesn't work.
Just has to be the right.
It has to be the right. I know. I'm sorry. I didn't make this up. If I
no, this is very helpful.
I'm serious. It's almost embarrassing to admit, but if it's the right arm, it subsides. If it's the left arm, it does no good. It enhances. It makes it worse.
It enhances.
It actually causes the whole thing to be more dramatic.
Very interesting. All right, so I run the whole thing because I thought that the phenomenology and the history are both just fascinating. And when you think of the situation on a phenomenological level, you would have to characterize this as a paroxysmal dystonia. Most of us would have done that, would have characterized this as a paroxysmal dystonia with intermittent jerking. And in fact, if you look at the jerking is fairly regular. In fact, if you looked at the jerking right about here,
Leg right here, you can't control the left side. But if I put my arm,
you can tell that particular jerking is actually quite regular. In fact, then he's saying that the movements begin in the left leg, and you can see that there is still the jerking in the left, and it's fairly regular, right? And so this is a paroxysmal dystonia with intermittent. You could almost think that this reaches almost some of those myoclonic conditions. But if not, you could use the term clonic. And of course, if you think in terms of that, you would say, wow, this is in many ways very much consistent with a Jacksonian spread of a focal seizure, but you just heard that the VO EEG is negative, so it couldn't be, we think, unless, of course, the test is not the final determinant of whether this is epileptic or not, and therefore, here is why it's important to characterize it, because, in fact, this is what anybody else, if an EEG would have been positive, characterized as a focal motor seizure with classic Jacksonian spread. So this man had a remote stroke in the right hemisphere, and I looked back, this was 8 months prior to that EMU visit, and if you look at this particular scan, you realize in a relatively quick inspection that this is not really a stroke. In fact, this man had a glioblastoma multiforme. And the question is, how did he present? So, of course, as you heard at the beginning, he had an EMU admission. The EEG showed no correlation. Obviously, the testing ultimately proved to be, as it happens in some cases, not sensitive enough to picking up the abnormal electrical activity that was in fact happening and driving the paroxysmal dystonia, but we ended up calling it paroxysmal dystonia, I suppose, because there wasn't an EEG. But why should the EEG have been? So, by the way, there were two problems here. One, that we put too much emphasis on a negative EEG and then trying to explain this in any other way, when in fact it would have been easier for us to say this is a focal motor seizure. The second, and by the way, this is why we then here separate in terms of the testing cutoff. This is sort of the second layer. If the test is positive, then we say, oh, well, it was a seizure. It is not a movement disorder. but a disordered movement. But if the electrographic correlate is absent, then we would refer to it as a movement disorder. And in a sense, this is sort of an artificial thing, because we now have this patient in front of us. We can understand that there is a progression of arm to leg. In fact, there is an aura with the abdominal movements. There is a sensory trick, by the way. We think that sometimes a sensory trick is exclusively the domain of dystonia, and certainly we can call this, as a result of that, paroxysmal dystonia with a sensory trick. As you saw, the man could alter the behavior with the right hand, but couldn't do it with the left, which is an interesting element to the closed loop sensory feedback that we know dystonia is responsive to. But then the other issue is the duration cutoff. So when does a movement become too long for paroxysmal dystonia, which is, of course, a term we could have used here? Is it here? Is it here or there? So is it within 5 seconds, and then maybe this paroxysmal dystonia could be qualified as a tonic spasm, or is it beyond a certain time? And then in that case, it would be a tonic spasm that strings together into what we would then refer to as a focal seizure. Ultimately, a paroxysmal dystonia is an expression of abnormal electrical activity somewhere. If it's picked up in the cortex, we then think it's epilepsy, but the activity could be from anywhere else. And certainly we now understand that paroxysmal disorders are really the expression of network abnormalities. So even if the node, the active node is beyond the cortex, you could imagine that the loops will run, particularly in the striatal frontal networks through the cortex at some point. Obviously, most of our standard clinical testing would be insensitive to picking up the kind of tonic spasms that we may see otherwise in people, say, with MS, for instance, or with other conditions.
And that is,
here's the same patient who went to the hospital, and
if
he
I
has
put
this
pressure
other
there,
behavior.
there it is.
Mm-hmm.
Where it's not with your right.
That isn't a controlled. See what I'm saying?
Yeah, that doesn't happen with the left.
No, with the right.
Yeah,
The right, I'm
that
sorry.
happened.
So here he had another behavior. He said, oh, by the way, if I put myself down and put pressure on my left hand, look at the movements that I have, right? It doesn't happen. It's this. Look at
If
the
I
movements
put
that I
pressure there, there it is.
Mm-hmm.
Where
and
it's
it
not
doesn't
with your
seem
right.
to happen with the other hand. So what is this? And that's a self-induced jerking. That is what we call clonus. Now, you could call it tremor, stimulus-induced tremor. Certainly, it is a tremor-looking manifestation, but somehow we are not using this kind of abnormality as a movement disorder, but as a disordered movement, of course, in the context of upper motor neuron involvements. This is a pyramidal feature. If the tremor was spontaneous, then we would refer to it as a tremor, as a movement disorder. And again, I'm trying to be provocative and trying to keep you thinking about the boundaries between what we call the behaviors that you see, and how arbitrary that definition may be. You have another patient.
If I
Normal, without any tricks.
I think the volume isn't as good. So this is a patient, as you see, that just a few months ago had this abnormal pressure in the right foot, and then began to walk funny. You can see that that's what she has. She has what we would call a right foot dystonia on walking. It goes away when she changes the motor program, and if she walks backward, then it goes away. That's a feature of dystonia. Is an action-induced task-specific movement, and therefore, if you change the task, the behavior disappears. You can see here she's able to march, which also alters the behavior. And then she has these episodes of right arm flexion and hand clenching. We don't document those here because they were not present, but she was saying, I was having those events too. Very much reminiscent of the patient that we just saw. What else happened to this patient?
Hold it up, strong. Strong, strong, keep it up, 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 up.
So you can also tell that she's just not having dystonia, but in fact, there is weakness. Remember, the other patient had clonus, so we knew that it wasn't just this paroxysmal dystonia, clonus was part of it. So there was a pyramidal involvement. It was not just dystonia, and here you see that there is, in fact, also hyperreflexia with, again, clonus on the affected side. Hyperreflexia throughout, but clearly a little bit more on the right, and then clonus on the right. So this situation is kind of similar. You have dystonia, you have a paroxysmal dystonic event as well. That one is undocumented. And then you have a pyramidal difficulty. So overall, you're seeing a very similar picture to some extent than the other patient, with, of course, permutations in terms of the flavor. And when in this situation, you always look for an MRI because it's a very asymmetric, in fact, in this case, unilateral manifestation. And what we see here can never be confused with a stroke, as it was the case with the other patient. And of course, this is much more classic of what you would think of as a primary brain malignancy, and particularly in this case, again, glioblastoma multiforme. What was the presentation here? Well, we could say, well, foot dystonia with superimposed paroxysmal dystonia or focal seizures. Certainly interesting. There were events that were reminiscent just as much of what you saw. But here, perhaps a more persistent foot dystonia was the key element in the context of beyond dystonia, pyramidal weakness. So where we are in the neuraxis is sometimes how we also think of whether a disorder is a movement disorder or a disorder of movement. And we just had two examples of cortical expressions, and you have both a positive with a focal seizure, which could have been thought of as a paroxysmal dystonia, and a negative manifestation with pyramidal weakness that of course can go all the way down to hemiparesis, right? And then you get into the basal ganglia and brainstem, and a lot of what happens within those structures are going to be the domain of movement disorders, we think, just because we've kind of figured that that is our domain. But then look at the spinal cord, where now you have a separation. Rigidity is movement, spasticity isn't. And then in nerve and muscle, well, we don't claim those, right? Because we are centralists. I joke that we don't care about the peripheral abnormalities that yield abnormal movements.
The gait that I'm going to demonstrate now is the hemiparetic gait. This gait, if we were to demonstrate it, we need to be able to show the extension of the leg and internal rotation. So the leg is too long. We get circumduction with the paretic side. But very importantly as well is that the upper extremity is very much involved. And so there's adduction at the shoulder, flexion at the elbow, pronation at the wrist, the thumb is tucked under, and a cortical fist. So this is the position of the hemiparetic gait, with the other side being normal, having normal associative movements. You can actually hear the pattern of the gait as well, as we have circumduction for the paretic side. Again, watching upper extremity postured into the decorticate posture, lower extremity is actually circumducted, coming around.
Right. So I put this video here because it's just a beautiful demonstration of the way teaching used to be done. I just love the way this is done. But of course, mostly because I want to show you
as you typically would be.
And what I mostly wanted to show you that is because this patient was thought to have a stroke. Now, she had an 11-year history of right shoulder pain, ultimately diagnosed as frozen shoulder, then depression, then this progressive gait impairment, which was characterized as hemiparetic. And as you see now, it couldn't have been because you don't see the circumduction, but more importantly, the arm is not flexed. So this is not a hemiparetic, but very, you could imagine that such a statement could have been done. This is in fact Parkinson's gait, a hemiparetic gait, and you can tell that this individual would have responded beautifully as it did. It's unlikely that we find patients with a decade worth of symptoms of Parkinson's that hasn't been diagnosed. It's very rare. It's also a good example of someone's response to therapy and then the complications that may occur because this particular patient developed dyskinesia very soon after the initiation of treatment, even though you could imagine that she would have abide by the old dictum that if you hold off on the initiation of treatment, that you would also delay the dyskinesia. That's really not the case anymore. But so it's very interesting that here we're talking about this interface between a hemiparetic and potentially hemidystonic, hemiparkinsonian, and of course it's so interesting that there are elements of one versus the other. Of course, we movement disorder neurologists would have separated out the hemiparetic versus the hemiparkinsonian gait with dystonic component, but I just want to point out that there is still an overlap in terms of the neuroanatomy. Now, the other interesting end of the neuroaxis spectrum is on these movements. There are two movements here that looked very much slow, but they are in fact hyperkinetic. It's just interesting to say that these are hyperkinetic disorders, and yet they are very slowly moving. The patient on the left has cramped fasciculation syndrome, never tested for voltage-gated potassium channels, although we suspect that could have been the case. Particularly now we know that Casper would be the correct antibody to look into for these patients. And the patient on the right, stiff person syndrome. This was anti-GAD positive stiff person syndrome. You can see that both of them looked on the surface very similar. They are both stiff. And what happens is that in one situation, we're talking about a hyperkinetic muscle disorder, with cramps and fasciculations, of course, being the key aspects of the muscular hyperkinesia. And then on the right, the stiff person syndrome patient is another hyperkinetic movement disorder, but the hyperactivity is, of course, mostly muscle hyperactivity from rigidity. So you have stiffness of different flavors, giving rise to, on the surface, very similar manifestations. They are also paradoxical because they are categorized by us as hyperkinetic because there is extra movement, yet they are very slow. These are within the spectrum of what sometimes we refer to as non-Parkinsonian slowness. There is a slowness, but we would not refer to, or shouldn't, I guess, based on what it means, refer to these patients as bradykinetic. They are slow, but not bradykinetic, even though you could imagine, but wait a minute, they are technically brady because they are quite slow. The slowness comes from the hyperactivity of the movement abnormality, but really not because of the overall movement or the overall behaviors. At any rate, I'm trying to be provocative here as well, because less movement due to more activity of the muscles is what you see here. So we're kind of now down in this category, and the differentiation between rigidity and spasticity becomes quite important for us, even if I would later argue that just because one is rigidity isn't the domain of exclusively the movement disorders, neither the spasticity alone being then the domain of another field. So be that as it may, but that's sort of how we kind of split those. And then, of course, the peripheral movement disorders, myokymia and fasciculations are really quite important in that I consider them peripheral movement disorders, but perhaps we are, by virtue of our central predominant framework of classifications, not often thought of as such. Look at these two left-sided hemifacial movements. They are jerky, but I'm going to argue that there is more clonic than tonic on the left, more tonic than clonic on the right. And it turns out that these two patients were referred for hemifacial, well, they were thought to have hemifacial spasms. They were going to have botulinum toxin injections, but there was a key difference. The one on the left had these movements that were perhaps excessively clonic. And in fact, an EEG was obtained, was negative, but then an EEG fMRI colocalization, which expands the sensitivity of the EEG, captured that there was an abnormal electrical activity on the homuncular region corresponding to the face. And in fact, this man was treated with carbamazepine. The man on the left had classical hemifacial spasm due to transynaptic transmission at the facial nerve. So here you have very similar behaviors, except for the clonic-tonic component versus tonic versus, the overall shape being a little bit more clonic on the left, a little bit more tonic on the right, but very different manifestations. So one is a central movement disorder due to cortical activity, epilepsia partialis continua, and the one on the right had another abnormal electrical activity, but rather than in the cortex, in the facial nerve. Technically, both of them were essentially hyperactivity, normal activity of either the cortex on the left or the peripheral facial nerve on the right. Before the advent of botulinum toxin, both of these patients would be treated similarly with carbamazepine. So even though I'm just saying, well, this patient on the left would have benefited, in fact, carbamazepine on the right with botulinum toxin, both of these patients would have benefited with carbamazepine, which as other sodium channel blockers are helpful for abnormal electrical activity that emanates not only from the cortex, but also from the peripheral nerves. So it's just interesting that the phenotype is overall close enough, but then the underlying source of the neuroanatomy is so different. So it's, to me, fascinating. Now, this brings another layer to the classification, which is the contraction sustainability. I'm going to contraction and amplitude. So contraction here is the idea that there is this boundary between tonic and clonic. And when does a hemifacial movement become too tonic for focal epilepsy, or too clonic, I would just say, for hemifacial spasms. So as you can imagine, if you're to the left, then that, if it's clonic, then that might be epilepsy. But at some point, if it's more tonic than clonic, that might be thought of as a hemifacial spasm. So here is the contraction amplitude cutoff. So these are two patients with myokymia. And you can see how you could confuse these patients with dystonia, or, and this is the sound of the EMG that you heard, that's high frequency motor unit discharges, classical of this condition. And you can see, of course, the myokymia in the patient on the right is distributed not just in the hands. But here, the point that's important to make is that you can see these displacements of the fingers, but they are not large enough to qualify as tremor. They are not pattern enough to classify as dystonia. And here you then have to sort of create a situation where you are saying there is an amplitude below the cutoff for these other conditions. And here you can see the patient on the left has myokymia as well, but the patient on the right has a hand dystonia with these additional movements. Some of them could be thought of as perhaps intermittent dystonic tremor, and we call it such because there is really tremor associated with dystonia more than any specific features of this tremor. And so it is, to me, fascinating that the amplitude differential between these two, one a peripheral, the other a central disorder, is quite slight. quite slight. I mean, here in some occasions you can see that the amplitude perhaps goes above and beyond what you would think, but otherwise, really quite little. We would typically say the larger amplitude of finger movements and the position dependency, which you can see sometimes in this particular patient on the right, might be clues to distinguish that as dystonia from myocamia of the patient on the left. So let's move to even more complexity, and that is getting us into the concept that even well-established disorders are going to have a spectrum, and that has become very, very clear with the understanding of genetic underpinnings for many of these conditions. So, but first, the phenotypes can go from pure myoclonus, and that would be a movement disorder, to progressive myoclonus encephalopathy, of course, not a movement disorder, even though myoclonus is part of it. On the right, you have hypokinetic disorders, and you saw an example of cramp fasciculation syndrome, a hyperkinetic condition, and then spasticity at the bottom as an example of really a hypokinetic disorder that isn't a movement disorder. So the complexity is, I think, partly brought artificially by us by virtue of the classification systems we've enacted.
I wonder if I've got adrenaline pumping around, it might not get one.
Yeah, well, that's why I was telling you just to run.
Right, okay.
You made a big deal out of it.
It was part of a video, still I think available on YouTube without a diagnosis, called Michael's Funny Feelings, 30-minute videos. This is the climax of that video. The man shows all this large workup that he's undergone, and he runs quickly, and this is what happens. Get these movements. So we would classify this as, I hope all of you, as a paroxysmal kinesogenic dyskinesia. And the term dyskinesia implies we don't really know what we're talking about. It's probably dystonia, little chorea, maybe choreoathetosis. But dyskinesia hides the idea that these are going to be pleomorphic movements. But the point I wanted to make with this is to ask you, if you have this person or a family member, what else would he or a family member also have? And unfortunately, I cannot play the game well here. I probably should have taken you up, Sudhir, with the idea of trying to get this. But if you mark this, you would have been right until very recently. You have these patients or themselves have a family history or personal history, or may have a family history of infantile convulsions with choreoathetosis, benign familial infantile epilepsy, paroxysmal torticollis episodic ataxia. That's because PRRT2, the gene associated with this, has all these potential abnormalities that are other genes too. And it turns out that now we know that, in fact, these patients can also have absence epilepsy and paroxysmal exercise-induced dystonia. We separate paroxysmal exercise-induced dystonia from paroxysmal kinesogenic dyskinesia because we think they're so distinct, yet the same gene can be associated with both manifestations, giving us pause as to the importance of the classification that we've established in terms of what these patients look for, and that creates a lot of problems. So the same gene can cause many different phenotypes. Most of us know that. In not all patients with these conditions, paroxysmal kinesogenic dyskinesia, non-kinesogenic dyskinesia, or paroxysmal exercise-induced dystonia, have mutations in these classic genes, PRRT2, MR1, or SLC2A1, which is the gene for GLUT1 deficiency syndrome. So now when you think of, for instance, PRRT2 and SCL2A1, left and right respectively, you have the paroxysmal kinesogenic dyskinesia spectrum under PRRT2 and the GLUT1 deficiency syndrome under the SCL2A1. And what happens is that you are essentially in the overlap between epilepsy on top and movement disorders at the bottom. So you can see here that if in fact these patients can present with epileptic phenotypes, depending on the age, for instance, in PRT2 could be infantile, in SCL2A1 it could be in childhood, But then later on, they may not have any epileptic phenotypes. It is the same gene, and not only the same gene, but the same mutation within the gene. You can then have later presentations with disorders that we would not classify as epileptic. Yet I hope that by now you're beginning the sense that, in a sense, everything is epileptic, right? Because anything that is paroxysmal should be associated with abnormal electrical activities that gave rise to a paroxysmal event. Whether we classify it as epileptic or not is highly dependent on the testing. The first of the layers of complexity we discuss about, if it is AG positive, must be epileptic. But if we had electrodes to probe into epileptic activity into the basal ganglia, we could have conceivably determined that all of these other conditions listed in red toward the bottom are in fact epileptic as well, assuming that's how we're going to classify conditions. Channels in certain parts of the brain that are triggered. The patient hospitalized, and boom, right there had the classical manifestation that you see in these patients. Right there had another one. This is a patient with essentially an LGI1 mediated facial brachial dystonic seizures. You can see though that the point through this is that with the same set of potassium channels, you can have a peripheral hyperexcitability disorder, an epileptic, that's the Casper-2 would be the one. Morvan syndrome is perhaps the more classic of the examples, but neuromyotonia and myokymia can also be part of the spectrum. The same set of voltage-gated potassium channels could have a separate subunit affected, the LGI1, and that could give rise to typically epileptic limbic encephalopathies. And could then be associated with a combination of what we would refer to as dystonia and seizure. And in fact, LGI1 brought to the fore the problem with that classification, because here, this is an example of a facial brachial dystonic seizures. Dystonic seizures. Is it dystonia? Is it seizure? Or is it both? And essentially here, we're trying to continue explaining things in the way we have. Well, here you have an example of somebody that, of course, has a paroxysmal dystonia right there. That's a paroxysmal dystonia affecting the arm and the ipsilateral face. And by the way, half of the patients have an EEG that is abnormal, but half of them have a normal EEG. And that's part of the reason why it is dystonic seizures. I guess we admit that there's probably an epileptic component here.
You didn't? You're not aware?
This is an example to show you that it actually changes the site, could change the site. This is now the same patient with episodes also having on the left, perhaps milder. But look at this. This is also the same patient.
Goddamn, don't be a mistake.
These were before he actually came to the hospital. And these were different episodes. They were not quite as stereotypical as the ones you saw. Right? And you wonder if perhaps to some extent he was doing the movements and everything else was a way, subconsciously perhaps, to hide the movements. Right?
I'm done.
Okay.
I find it fascinating how these movements could in fact include, span a wider range of behaviors. Now, I'm going to end with these movements largely because if you look at this, it's hard to put a label to them. In fact, it's so hard to put a label to them that they were described as complex movements. Complex movements at onset in narcolepsy with cataplexy. So these are movements that happen in the junction between wakefulness and sleep. So some of these movements are essentially the type of abnormalities that you would see, a little bit of almost a patient on the left lower corner, you would think that is almost a little bit of facial weakness with that, right? some stereotypical movements, but these movements challenge our nosology. Where do we put them, right? Where do we classify them? A centralist is not quite dystonia, it's not tremor. Is it a stereotypy on the left lower? Maybe that could be, but hard to otherwise put a name to this. And then this movement, which I find, now we're saying a number of patients with paroxysmal chorea of what perhaps might be a PNKD-like, so paroxysmal non-kinesogenic dyskinesia. So just an episode of this, it is a number of these patients are thought to be functional because they have this abnormality. They continue to be awake throughout the event. They can respond somewhat, but they have this movement, which of course I would say is okay to call them chorea. But when you say chorea, you're saying it is a movement disorder. It cannot be epileptic. And yet here, this patient had consistently, there was the first example of somebody with very good, consistent EEG abnormalities associated with these events. And I think that this really does quite a bit to dethrone the idea that if we say chorea, we know we're talking about a movement disorder and it can never be epileptic. And in fact, here is an example. There is going to be a recent publication of a few cases in a series of patients like this. And it's just fascinating that the movement can, in fact, be epileptic in nature. So I think a call for us to keep our minds open and not simply use labels that we have come to become quite comfortable with. So I hope that I've raised the issue that some of our classifications are really difficult to do. They are arbitrary. The key to getting us into a different state has been the understanding of the genetic underpinning of a variety of disorders, many of which are paroxysmal, as you see here. The same genes having expressions that are epileptic versus non-epileptic, of course, movement disorders, and then a number of disorders of movement that are well established to affect movement in a specific manner, and yet, and I didn't even touch this, this would be sort of a bit of a separate lecture. These are conditions that we have to keep in mind that are not necessarily in the classical grouping of movement disorders. So just remember this as best as you can. Just one example of epilepsia partialis continua for sure. And of course, other disorders that we couldn't really have chance to review. So abnormal movements that are of any kind will probably at the end be related to activity that is abnormal electrically somewhere. If it's a focal seizure, of course, the activity is going to be at the cortex predominantly. That's how we can pick it up. But there could be in the striatum with paroxysmal kinesogenic dyskinesia and non-kinesogenic dyskinesia as well. The neural networks is what we now have been thinking of as a way to explaining these so-called ictal zones. But then you can have, of course, abnormal electrical activities elsewhere for hemifacial spasm in the facial nerve, for the cramp fasciculation syndrome in the neuromuscular junction. When is it that we are going to use the nosology of movement disorder? Well, I have this cartoon here mostly as a joke because I don't think that this is a way to say this is how we're thinking, right? Short movements must be tonic, long movements must be focal seizures in the direction of paroxysmal movements. The sustainability of chronic movements, well, if it's a little sustained, we call it tonic. If it's unsustained, we call it clonic. And you can then see examples of conditions that you would think of in that. And then the description of phenotype, you can imagine a movement disorder, hemidystonia, rigidity, but hemiparesis and cramp fasciculations as non-movement disorders or disorders of movement. And the last, which is sort of how we began with the order of appearance. If it's early, we think of a movement disorder. If it's late, we don't think of a movement disorder. So I hope that this gave you a case-based taste for how artificial we categorize abnormal movements, and really how keenly aware we have become of the pitfalls on testing, particularly EEG, for instance, and others, in terms of defining how we call things. The advances in genetics and immunology, I think, have really done the most toward altering, or at least forcing us to rethink how we have categorized conditions. And ultimately, what we need to think about is that it renders us clinicians the best really at continuing to avoid the pitfalls of testing alone and continue to think about the patients in terms of how they present. And with that, I thank you. I wanted to briefly had a time.
Okay, come on back.
For those of you who haven't seen this particular patient, I thought that this is nice in the spirit of a patient with a disorder of movement. This was just a beautiful one. I don't know if many of you have seen this one, but I thought it's just fascinating because she was thought also to be functional. These movements, as you can see, there is these lesions on the knee. That was the clue to knowing what this condition is, which I think is important to recognize. It is a disorder of movement, no weakness, but when she puts a little bit of weight on either limb at a given position, such as here, when she's walking, of course, every time that she's bearing weight, you see these pelvic movements, right? Except if she's keeping walking, then it looks like she's kind of dancing a little bit. And I love this case to remind us that you don't have to have a movement disorder. That'd be neurological. We talked about central and peripheral, and of course, all the spectrum in between. And this is an example of someone who has coxa saltans, essentially a continuous subluxation because of weakness at the hip joint. And there are examples of other snapping joint syndromes that give rise to movement disorders that aren't really movement disorders because they aren't technically neurological, although just looking at the manifestation is important to define what we have. And with that, I'll stop sharing, and I'll be happy to entertain questions or comments of any kind. Thanks, everyone.
Thank you. Great talk, Alberto.
Thank you.
When did I think the whole problem has started when movement disorders started going outside the basal ganglia. Initially, it was supposed to be basal ganglionic disorders, and I think some of them went outside, and then you took them into movement disorders, and now we are finding that some of them are epilepsy, some of them are peripheral things like that. So they're going on. But what would you finally say is what will remain as the quintessential movement disorders?
So my goal with this lecture is to abolish the boundaries. I think any movement abnormality is technically a movement disorder. And that's why I'm trying to be a little facetious with separating this is a movement disorder, this is a disorder of movement, is a language component that I think we have self-imposed. It is arbitrary, it really shouldn't exist. So at the end, we're neurologists, and just because we are calling ourselves movement disorder neurologists, it doesn't mean that we should artificially create these boundaries at all. So I'm hopeful that that when we say movement disorders, we really mean any disorder of movement. So expanding it well beyond the basal ganglia.
So it becomes everything. Then it becomes hip disease, joint disease, antalgic gait, everything.
Well, so if we had seen that patient, that I showed you last, I sent it out there because it's a provocative example. It'd be important to recognize it is not neurological. It's funny because in our residency program, one of the first, a case presentation always goes from the first question, neurological or non-neurological? Well, if you are thinking neurological, you go down the wrong path for that particular patient, right? But the movement she had is interesting. It's a fascinating movement. It just so happens had nothing to do with any pathology of the central or peripheral nervous system. It's nice to remind us that we are engines and that sometimes our movements may fail. Sometimes we see this with antalgic gaits, right? People who are walking funny because, I mean, to me, that's a movement disorder. They're walking funny. That movement is abnormal, but it's not neurological if it's antalgic because of hip arthritis, whatever, you know. And it's important for us to recognize that because the workup will be different. The treatment will be very different as well.
This is a great talk, Ispe. I think the point is the neurology is slowly going from localization, because initially we used to ask about where is the localization. It's now not about localization, it's the circuit. Where the circuit is involved, that is where you are standing, which side of the fence you are. If you are a movement disorder specialist, probably look at the movement disorder. And if you are an epileptologist, probably you look at into epilepsy. The initial description that will go like that. We have a few questions. I'll go by one so that some of the audiences will be able to looking forward for those answers. Harsh Gupta has asked, is there any comment on the confusion of terms within the movement disorders, such as clonic perseveration and stereotypy?
Boy, great question. Yes, there's a big deal of controversy. We don't know what, we each have a bit of our own definition about what these are. And it is unfortunate that because we call what we see, and what we see is not perfectly patterned with each individual, then we have versions of the movement abnormality that we give names to. Unfortunately, stereotypical movements are among the most abused of the terms, because in a way it's sort of second to dystonia, where if we don't know it, it must be a stereotypy. If we don't know it, it must be dystonia, even though these movements may not really follow much. So a stereotypy in terms that we have come to operationalize should refer to movements that are complex but repetitive in the same complexity. It is as if there were ticks strung together. And that's sort of the way I've always kind of thought about, at a simplistic level, of a stereotypy compared to other movements. There was another, I forgot the other term that you mentioned, but we really have a lot of difficulty with categorizing. That's why sometimes I prefer that we talked in descriptive terms, right? In the face examples, you could say there are jerky movements of the hemiphase that have a tonic component and a clonic component. I suspect the clonic component is greater than the tonic component. If so, I may be thinking about more cortical than peripheral. Now, on the other hand, you have very clonic components early on in post-paralytic hemifacial spasm, which are probably manifestations of facial myokymia. Very, very quick, very clonic. Here's the art of neurology to some extent, to distinguish a myoclonic from a myochymic, for instance, right? That to me is an important difference. You have patients with jerky movements. You saw a patient with myokymia, and you can say that it's a little jerky. You would think of myoclonus, and that's obviously both of them will be very different because one is central, one is peripheral. But I think how we call things remain very important. But if we cannot commit to something, I would rather just be descriptive, so that we're not necessarily going to enter into a path that won't get us far in terms of that patient's diagnosis and ultimately treatment.
And Kavita Srivastava has asked a question. In various disorders, including like progressive myoclonic epilepsies, primarily they are gray matter disorders with seizures or myoclonus, but they also have other movement disorders such as choreas and other things. So how do we explain that? Well, where do we put them? Where do those things sit at?
Well, I think that when you have, if you have a disorder that is mixed, if you have a mixed movement disorder, you have to be convinced it is mixed, so that then you think of which conditions are associated with mixed movement disorders. For instance, for us, when we say somebody has dystonia, Parkinsonism, chorea, and myoclonus, well, that's too many, right? But if true, then there are not that many conditions that would have a dirty expression. DERPLA will be one of the classical dentatorubropallidoluysian atrophy, classical example of a dirty movement phenomenology. But often the case is that we see jerky movements and we say, well, there is some dystonic tremor, some myoclonus, and I think chorea. And if you then do that, it's going to be terrible to focus the diagnosis correctly, because you have to be looking for chorea differentials or myoclonus differential. So I think the important here is not to jump into labels, especially if you're saying that you really see dystonia, really see myoclonus, and really see chorea. Most often isn't the case. Most often is we in our CPC, unfortunately, it was too late for India. The last CPC we presented is a patient that had really a very interesting dystonic phenotype with some ataxia. So I think that this was a cerebellar dystonia, and it was mentioned that the movements were consistent with chorea too. And the more we looked at them, no, I mean, there was a lot of this, but it was sort of in the context of a more pattern movement. But if you would have said chorea, then you're in a different category of disorders, and you can then do testing after testing after testing on the idea that there is some chorea here when in fact there isn't. So if you can keep disorders restricted to one or two phenotypes, it's good. If you're going to commit to a third phenotype, you really be better convinced that truly there is another movement, so that then you know that you have to deal with only disorders that includes 3 or 4 conditions, depending on how many you're dealing.
Usually what I also tell when people ask is, most of the diagnosis, what has been labeled from the initial symptom, the primary symptom, that is the anchor point. So that tells us where is the burden of the pathology starting from. And things progress over a period of time. And most of these are degenerative diseases. And it's not only just a gray matter, other systems get involved. So you develop various other systems that may be related to autoimmune disorders, or it may be related to various other, like a patient with Alzheimer's will develop Parkinsonian features down the time, or a Parkinsonian patient will develop dementia down the time. So the way you look at it, it's starting off a pathology. The diagnosis tells where the brunt of the pathology is going on. And I think probably there are a couple more, I think, case related. Probably I'll not ask those questions. I'll jump those specific case related questions are there. And I think there is one question which Shakti Burman has asked. Movement disorders are not only restricted to CNS only, now distributed to PNS as well. Very nicely described. Like to know the movement disorders like athetosis or tremors related to peripheral nerve disorder, for example, tremor in chronic demyelinating neuropathy and aphatic transmission hemifacial a sequelae of 7 nerves. So they want to know about the CNS and the PNS differentiation of the movement disorders.
Well, great question. So when you use the term tremor, it can only be central. Now, you could have a neuropathy that is so severe that has altered central networks, that sensory deprivation can alter central networks, and that's how you have a tremor. A tremor is by definition a central movement disorder. It depends on tremor generating circuits, which are only central. So athetosis in tremor, which I think the examples here, they're technically peripherally associated central movement disorders. They are central because you require a change in the in the brain, particularly in the structures related to cerebellar outflow, the cerebellar itself or its connections. And this is kind of important because, for instance, often patients may have a degenerative disc disease in the cervical spine, and they have a tremor. Well, you cannot explain the two, right? So you have spinal pathology, which is never going to generate a tremor. You need to go above that level. You need to go into the cerebellum and upper brainstem to have a tremor. So going off, you can of course have degenerative disease, but it should be doing nothing to the tremor. Same thing with myoclonus. Myoclonus is another distinctly central movement disorder, and that means that if you see true myoclonus and a radiculopathy, for instance, you cannot put the two together. Even if they're in the same limb, they are not going to one explain the other. So that's very critical. So it does matter what name you use it. So if you commit to a name, you have to know that that name would be related to something else. So tremor and myoclonus are going to be always central, always central. They might have a peripheral injury that could have altered central pathways, but the peripheral injury directly did not cause a tremor or a myoclonus.
Alberto, sometimes when the Guillain-Barré syndrome improves, they are left behind with a tremor, which is said to be due to asymmetric improvement. So the conduction in the nerves is, asynchronous, and that worsens the physiological tremor. So how would you?
Yeah, the best example of so-called neuropathic tremor is in CIDP indeed, and there are certain antibodies that do it. But the nerves, the peripheral nerves, are incapable of sustaining a rhythmic repetitive activity in this way. That can only come from the brain. So it is likely the case that the sensory abnormalities brought on by the neuropathy end up altering cerebellar pathways, the cerebellum itself, and generate a tremor in that fashion. So it's yeah. So it would not be an indication that only the peripheral nerve injuries is related to that particular manifestation.
Or maybe the feedback loop for the physiological tremor, that loop gets altered, and that's why you may be getting the tremor.
Exactly. Yeah. Very good question.
I think we'll end up with one last question, which once again Dr. Shruti Burman has asked. Tics, where does that fit? Is it a movement disorder or disorder of movement?
Well, so tics are in a very unusual category because one element of movement disorder implies that they are involuntary. And tics are thought of as involuntary, UN voluntary rather than IN voluntary, which means that there is some control of the movements. That if you have tics, you can control them. And by the way, that's one way to distinguish neurological tics from functional tics. I guess in the functional tics, people say, I have no control over my tics. Well, that would be functional. That would be a clue that is functional. So I consider that a movement disorder. The mechanisms are central. They're brain dependent. It's unclear how things happen, but it is also a problem with. I mean, at the end of the day, when we think of the manifestations of patients with Tourette, they have tics and they have obsessive compulsive behaviors. Tics can also be thought as a compulsive motor behavior, right? We think that these are individuals that check the doorknobs many times because that's kind of part of their compulsive behaviors. But in fact, complex motor tics may themselves also be thought of as compulsive motor tics, as compulsive motor behaviors. But that's why, as all compulsions, you can control them for a little bit. But if you control it too long, then they kind of come back with a vengeance. There is also a sensory component to tics. There is usually premonitory urges, and there is a sense of relief after the tics. So all of this suggests that it's not just a motor disorder, but a much more complex, potentially neuropsychiatric disorder.
Good, great talk, SP. I have been following you, this talk specifically from 2013, I think. So I heard it for the first time in Mumbai, where you had a five. And this has been always been a very interesting topic for everyone to understand. Where does a movement disorder start or where does it end? With this, I'll ask Professor Madhuri Bihari to give a concluding remarks and close the session.
Thank you, Prashant.
Madam, your mic is mute.
I enjoyed your talk, Dr. Alberto. It was really wonderful. What I have, I can make a gist of what you said, that there's no point in categorizing or compartmentalizing the diagnosis. You decide what the patient is having, and then we can find out the cause and otherwise. If we know the cause is stroke, then we call it a stroke. Or if it is because of a neurodegenerative disorder, then probably it is a movement disorder. And there's no point in compartmentalizing the whole stuff. And
very good.
We are not movement disorders specialists. We are a neurologist first, and that we should always remember.
Absolutely. We are neurologists to begin with. And all these boundaries are artificial and can get us into trouble if we stick to.
Not forget the basics of neurology.
Absolutely. Absolutely.
Thank you so much. Thank you so much. I enjoyed your talk very much.
Thank you once again.
Thank you. I'm delighted you enjoyed it. Thank you, everyone, for the opportunity to be in India for a little while.